COVID-19 pressing forward in the face. It's been a wild time for the last 2 months. We're glad that you could join us for this webinar from the Texas Society of Sleep Professionals. We had to cancel our fall meeting, and when we heard about something like this coming up about 2 weeks ago, we were just really pleased to have speakers that were willing to share their ideas and some of the protocols that they've come up with to reopen their sleep lab and to make sure that everyone stayed protected as we move on. For right now, I'm going to just introduce myself, Dr. Greg Holt, with a doctorate in physiology from the University of Florida College of Medicine, board certified in clinical sleep medicine in 2005. I've been an assistant professor of medicine and pulmonary medicine at Temple University in Philadelphia and a professor at Louisiana State University of Texas and Florida A&M. I'm the director of operations and polysomnography at Respiratory Quality Services in Houston and the current president of the TSSP. And joining me as a co-host and vice president of the TSSP is Dr. Cindy John, pediatric pulmonologist and sleep specialist, trained at the University of Texas Health Science Center, did a residency and fellowship there at University of Texas. She joined the faculty at UT Houston McGovern Medical School, and her role is expanded to the Associate Program Director of the Pediatric Pulmonary Fellowship and Medical Director of the Pediatric Sleep Center at Memorial Hermann Memorial City in Houston. And she is the Vice President of TSSP since 2018. And she will join us as soon as she can. But our first speaker is Dr. Barrantes Perez, Associate Professor at Baylor College of Medicine. He studied at the School of Medicine, Universidad del Rosario, Bogota, Colombia. Did an internal medicine residency at Pinnacle Health Penn State in Harrisburg, PA. Critical care, pulmonary, and sleep medicine at Wayne State University in Detroit, Michigan, and has been an officer and a current member of the Public Safety Committee at the American Academy of Sleep Medicine. We are very fortunate to have Dr. Perez here today. So I'll let you take it, Dr. Perez.
Thank you, Greg. Can you please advance the first slide? All right, good afternoon, everybody. I'm glad that we are able to join as a community in Texas and share our experience. The information I want to share to you is the mitigation strategies that we created in the Public Safety Committee in the ASSM. I will not take credit for creating them. Most of the input came out of my colleagues, but I will take the blame for whatever is hurting you. Greg, if you want to help me with the next slide, please. So we try to make a consensus of what you need to have your practice ready in order to operate in a safely manner and that the practices are no bleeding money. And we are aware of all the difficulties that are coming across the country in terms of getting PPE, getting technicians that are being furloughed, having cuts in the payments, inabilities to operate the DME companies at full charge as we did before. So we created a guideline how to operate and how to be ready when we are going to be opening. So this guideline got published back in the 27th of April. And what we are asking is that will you be prepared to open again? And there are different segments. So we'll start with the PPE. So as the CDC recommends, we should be having an officer that should be vigilant how much PPE you have to operate. So the idea is that if you have a count, you can prepare for how many days you can be able to operate safely without getting your technicians exposed or getting your patients who are not sick exposed. Most of the hospitals have one of those officers, and we would like the clinics to have the same. Ideally, you should be able to cover yourself with a PPE when you are contacting the patient. So the patients can wear one of those cloth masks and or a surgical mask. And ideally, if you are being talking directly with the patients, it should be nicer if you can use a face shield and a face mask, but the face mask is deemed to be the recommendation by the CDC. Can we move to the next slide, please? So this is the recommended PPE to do a PAP titration. So in the right corner of the computer, you guys will see those N95s that have a valve, the white one. That valve is an exhalation port. So the person who is breathing through it will not inhale the particles, but it will exhale. So you see, you are exhaling those. That's the reason why those masks are being forbidden in California, and they are nowhere available to be sold there any longer, because that is propagating the infection instead of helping. So if you are going to use an N95, you should be using one like the person who is in the middle, that is the green one. That one does have an exhalation port, and you will be protected, and you are protecting your patients if you are sick. It's recommendable that everybody gets test fitted. So you guys see a picture about that. And ideally that you test fit everybody in your lab before you start operating. Once you're going to do the PAP titrations, there are different kinds of PPE that you can use, and they are different costs. So the minimal standard that you should be doing, since you are going to be exposed to aerosolized virus through the mask, independently if you are using a filter, you're still aerosolizing from the leak around the cheeks. Even if you put a filter board in the inspiratory and the expiratory limb of the machine, you will still leaking aerosolized particles through the mask. Even if you have the mask that doesn't have any exhalation ports for preventing the CO2 retention, you still have a significant amount of leak. So that's the reason why you should be using the N95, the face shield to protect your eyes, and you should be using a gown. There are different kinds of gowns. Some people are using the bunny suits, and some people are using the regular disposable gowns, or these ones that I am showing, displaying. They are reusable, so that may ameliorate the cost. Now, if you want to be more fancy, you can use one of those poppers, but obviously those are quite expensive. You have to have a battery, and you have to have a lock for the battery, and that would be the optimal equipment to get exposed in an environment that has aerosolized particles. If you want to protect your personnel and your patients every day, optimal environment that you have a negative pressure room to do the titrations. So you are cleaning the air that is circulating. So when the room is going to be used for the next patient or for operating during the day, the particles are being cleaned, and you can just clean the surfaces. Or if you have access to a UV light machine that can UV light the room, it will be able to neutralize the virus after 10, 15 minutes of UV ray radiation. And that room should be ready to go either as an office, if you have the Murphy beds, or as the next bed for the next patient the next night. Next slide, please. So we also create a little bit of recommendations of screening. And the idea of screening the patients is you will be able to deter potential patients who are infected and they need to be quarantined before they are not contagious any longer, and they might need to have their test rescheduled. So there are multiple ways to do it, but essentially what we are asking is that you screen online or via phone, so you don't even have the patient to contact the environment in the lab. And the questions are quite simple. They are in the CDC or in the ASSN webpage. If the patient has respiratory symptoms, it is recommendable that they get postponed. It's not that we are not going to see them ever, it's just we need to postpone their test. The current recommendation from the CDC stays up for 14 days, but we are seeing in the Med Center patients who are still contagious or still positive in the nasal swab, even 4 or 5 weeks after. So that's something to take with a little bit of a caution. We also recommend that after you have done the online screening or the phone screening, you do a screening in the point of a testing. So when the patient gets into the test into the lab for the test, you check temperature. Not everybody who is sick is going to have a fever. But if you are actively sick, there is a good chance that you might have fever. About 70% of the patients have fever. So if you have fever, that's a person that should be asked to be rescheduled. And that's the reason I suggested to have the face mask for the person who is in the front desk. Either you have a plastic shield like they have in the supermarkets, or you have a face mask so that person doesn't get exposed to micro droplets from the saliva when they are talking to our other patients, not only through the airway. There is a possibility that you can acquire the virus through the eyes. And if they have a positive screening that they might have the virus, they just need to be rescheduled for another day. Next slide, please. So you also should screening your staff when they are coming in. So what we suggest is to check the temperature twice a day and to do the screening questions. If you have traveled recently in the last 15 days, if you have the fever, if you have been exposed directly to somebody who has COVID and you were not using your PPE, those kind of questions help you to know which personnel from the lab might need to work in a couple of weeks when they are not infected or the risk of infection is less. It doesn't mean that you need to furlough everybody. You just have to organize your personnel in a sequence that they can operate without exposing themselves or exposing somebody else within your lab and keep your lab operating. Next slide, please. The patients who are going to be admitted for a PAP titration or for an in-lab, you should consider doing a point-of-care testing when it becomes available. Not everybody has them, but at least we now have a Texas state webpage that they give us the locations where the tests are being available, so you can refer your patients to be tested there, because not every single PCP, or you will not be able to order tests as an outpatient today. There is still a shortage of the testing that you can do a day. But if you are going to bring somebody for a PAP titration, you would like to have it at least 24 or 48 hours negative before they get admitted to your test. So we would recommend to have the point of care if you get it. If you don't, at least ask them to have the test 24 or 48 hours before they come that is negative, so you minimize the chances of exposure. And that obviously might have some exemptions, and the exemptions will be people who can be done under a negative pressure with the full protection for the aerosolization of the particles, and that they need an urgent test. And I will say an urgent test is somebody who has chain stop breathing and is dying without the treatment, so that person needs it. A child who cannot live without it, they have significant CO2 retention and the current treatment is failing, that is an emergency. Somebody who is a CO2 retainer, COPD, and without the treatment is going to be readmitted over and over and over again, or somebody with heart failure. Those are the emergencies that need to be considered to be brought up to the lab early on. And we will suggest to have the negative pressure testing. If you don't have the negative pressure testing, at least a way to sterilize the room after you have done the test. I will suggest UV rays and the technicians to use a full PPE. Next slide, please. So for the infection control, you should designate somebody in your lab, the front desk secretary, somebody who keep up with the new recommendations, because they are changing pretty much by the week. So the two places to check is the CDC and the ASSM. We're trying to keep it up to date, and there is a link there. When you click in those orange or blue links, they will bring you where the most updated information is, and one of our members in the committee is keeping that curated and trying to be as fair and easier for everybody to get it done. So you just click on it, and it will bring you to up-to-date information. You should promote social distancing during your experience in the lab. So if you have your waiting area, you should arrange your chairs with 6 feet apart, so they have the social distancing. And everybody should have some sort of advertisement how to have a cough etiquette and respiratory hygiene etiquette and hand hygiene. And also, whenever you bring in somebody into the office, they should be wearing a mask, and your technician should be wearing a mask as well, or yourself, you should be wearing a surgical mask or a disposable mask if it's possible. And you should have plenty of hand sanitizer and areas where the patients or your technicians or yourself can wash your hands often. And once you have done any sort of procedures in the lab, you should be able to clean the surfaces with the solutions that the CDC recommends. Pretty much it's just chlorhexidine impregnated alcohols, is that what they are recommended to have it done. But also there are other cleaning solutions that might have just a peroxide or might have a chlorine-based solutions to clean up the equipment. The problem with the chlorine solutions is that they might fade the color, or they might promote malfunctioning of the equipment. So you have to look with the manufacturer guidelines or the recommendations to cleaning, what kind of cleaning solutions you can use in your equipment. Please, next slide. All right, so right now, what everybody is doing and everybody's incapability to do is to do portable sleep studies and auto CPAP everybody that you can. So what we recommend is that people who have the home sleep studies that they are not disposable, you should quarantine that equipment for 72 hours. The virus dies pretty much in 72 hours in most of the surfaces, except for the plastic that may last up to 8 days. So as far as you wipe them with the cleaning solutions and you quarantine it, there is a good chance that you will not have any transmission of the virus, especially the thermistors, that at least you have a way to use ethylene-based decontamination, and most of us, we will not. Even in the home hospital, you will not have that capability. Having those PITA for the thermistors that are not disposable and are going in the cannulas, going in the nose of the patients, we suggest that you wipe them, and then after you quarantine them for 72 hours. So your turnaround is going to be smaller. You cannot have that many nights per patient. So I will suggest just one night at this time will suffice to try to make the diagnosis with a home sleep study instead of doing multiple nights. The way to return the home sleep studies, many companies have opted out to just mail them out to the patients, so they minimize the transit to the lab. But if you cannot do that because it turns too expensive and you cannot even get a penny out of that test, what you can do is just follow the social distancing to release the equipment to the patients and have them pre-screened before they come in to pick it up. All right, please, next slide. So what you need to do is define how bad is the environment outside, and according with that, there are some guidelines. So if the community transmission is none to minimal, that meaning as we were back in January this year, there are some recommendations. And if you have a minimal to moderate, so what we are right now, there are different recommendations. And if you have substantial community contamination, that was 3 weeks ago when all the hospitals were busy. Let's say New York, everybody was dying and there was enough nurses or people to take care of patients. That's what you consider substantial community spread. So next slide, please. So non to minimal, pretty much you just have to test the cases that you think that might be positive and quarantine them and just follow social distancing and your own protection with the mask and the gloves and cleaning your hands. That's whatever you need. And you will be able to gather those patients in your waiting room as far as they are 6 feet apart. Next slide, please. So minimal to moderate, that's what we are right now, that there are multiple cases in the community. There is an opportunity that they might escalate. So when the schools open up, there are going to be more children who are going to be infected. When the swimming pools operate at more capacity than 25% or even at 25%, we will see more spread. And we will see peaks of the infection as we start seeing it now in Texas. And next slide, please. Unsubstantial will be like we were a couple of weeks ago, how New York was a month ago, that pretty much you need to be state quarantine and you have to minimize the transit in the hospital and maximize the use of the PPE. Next slide, please. So this is what the CDC recommends. I'm not going to go through this very busy slide, but essentially it's saying you have to prioritize who are you seeing, try to see everybody through telemedicine, and if you have patients who are symptomatic, don't let them into your lab. Next slide, please. So this is how Texas is doing right now. Whatever looks very purple, that's where more new cases are occurring. So you see New Orleans, how busy still, it's very purple. So Texas is still in the not that bad. So we are experiencing about 30 to 60 new cases for every 100,000 inhabitants of the state. And we have few of the states that are in the top 50 counties in the country. So we have Montgomery, we have Harris. So Harris is number 20 a couple of days ago, and Montgomery is like number 24. And at least we are knowing the very special list of the 20 counties with more deaths in the country. So we don't have any counties down there, but we have them certainly in the first 60. So we have a couple. Next slide, please. So this is Texas, how it is. So as you see, it's something between 31 to 62 new cases, but also we are having a limited amount of testing. So we might have more cases, we just don't know it. But most of the states across the United States are in the same situation. Next slide, please. So this is how it's going by county. So if your county is one of those that doesn't have any cases, well, you might be lucky and your lab might operate a little better and have more testing done. But if you are in the areas close to the Med Center or in the areas close to Louisiana, probably you cannot do so. Next slide, please. So this is the CDC tab from the last week. This is 2 days ago. So Harris County is pretty much leading the amount of deaths. But if you compare this to New York, we are not having as many deaths as New York does. They are going in the thousands, we're going in 200. And Harris County has 10,000 new cases. New York has way more than we are. So next slide, please. So let's move to the next slide so we can expedite a little bit. So if your community transmission is substantial, and that's what we currently are, you should consider postponing and reschedule the non-emergency in-person appointments and try to conduct your operations through telemedicine. And your patients who are gonna be coming to the sleep center, they should be tested with a reasonable time frame. Let's say that at least 3 or 4 days that you get the results and they are negative before they come in. And they should be screened both online and as well when they came into the center, okay? If they turn to be suspicious, they should need to be postponed. And at this time, I will recommend if you don't have an emergent case and your lab can sustain a little bit with the money, just don't do cases that are not emergent. Now, there are patients that need to get treatment and they cannot be diagnosed and treated without having a formal titration because they have complicated backgrounds or whatever is the case. Those ones you can bring them in, but if you are going to do it, please try to use the full PPE and negative pressure rooms, or there are ways to create negative pressure rooms even if you don't have the full installation. So you can put a high efficiency filter inside. That's one way to do it. Or there is descriptions in the CDC website how you can create the negative pressure room with 2 fans. That one, we don't know how safe it is, but the high efficiency filter inside of the titration room seems to be working for most of the hospitals across the country. Next one, please. So we will ask you to keep the visitors limited. So for your sleep study, you usually don't need a visitor. And if it's necessary, let's say a mom that has to come and accompany the child because the child will not be able to be inside and tolerate the titration because let's say there's somebody who has Down syndrome and is already 25 years old and cannot be reassured because has severe developmental delay or social delay. That one will just limit it to 1 family member, not all of them, and as possible, stay outside of the room. So if you cannot do remote access because the patient doesn't have a capability via internet, well, that's a patient that you might consider just to try to get it over the phone. And if you allow me to see the next slide, please. Medicare has created some exemptions in this time of the coronavirus. So they allow you to charge for a full telemedicine consult without having a physical exam as a full charge. So you're not losing money when you're doing telemedicine. So investing in a little bit of getting a secure software to do the telemedicine encounters will allow you to don't lose money and keep your lab active. And currently, they are not requesting you to have a diagnostic or a home sleep study to approve the treatment by the DME for a PAP. So they just want you to document that you consider in your medical knowledge that the patient may need treatment. So the problem with that is that they haven't said for how long that's gonna go, and then if the pandemic goes away, if those patients then after need to be requalified. We don't know that yet, but currently, if you want to do it, you can order it, and Medicare will pay for it, and the DME will allow you to release the equipment. The other thing that we don't have clarity, and they haven't made the guideline, is if how often you have to bring them back and how you are going to do the compliance report and download. I assume by now still the same rule that we have, is the 30 days, and that can be done online these days pretty much, except few equipments that you need to download from the small SD card. Next slide, please. So try to postpone whatever you cannot do as per titrations, and if you are going to do it, use your negative pressure room. I think somebody cannot hear me, is that right? Can you hear me better? All right, somebody text in the chat that they cannot hear. I hope now it's better. In women or patients that are high risk population, we suggest to delay them. If you can auto-pop them, just auto-pop them. And if you absolutely cannot delay them, bring them as an emergency. And try to circulate your home sleep studies, as I mentioned before, that you either use by mail or you can quarantine them for 72 hours, so you increase the amount of circulation. So in the guideline, it might suggest that the ASSM went in cahoots with the ICAMAR people because they are the only company who has a disposable HSAT device currently in the market. That's the reason why we'll say they're considered, no is mandated, okay? So just be mindful about it. If you have your all equipment or the equipment that is not disposable and is functioning, you can circulate it. You just have to clean it up and make it proper to be used, okay? Next slide, please.
Thank you, Dr. Barantes Perez. That was very informative. I just want to remind everyone that if you have questions for any of the presenters today, please put it in the chat room. We'll try our best to get to it at the end when we have the question and answer session. Our next speaker is Dr. Vikas Jain. He is a board-certified fellowship-trained sleep medicine specialist who completed his fellowship in Stanford University. He is a leader in the field of sleep medicine and currently serves as an advisor to the American Academy of Sleep Medicine, as well as on the board of directors of the Board of Registered Polysomnographic Technologists. He has also earned the distinction of Fellow by the American Academy of Sleep Medicine. He is currently an adjunct clinical assistant professor at Stanford University Sleep Medicine Program. He has previously served as a health system clinician at Northwestern University, as well as an assistant professor at the University of Oklahoma. Thank you, Dr. Vikas Jain.
Thank you. So thanks for the introduction. So I'm going to just try to bring some perspective in terms of how we've been approaching seeing patients during COVID-19, especially as a doc in private practice. So kind of as previously stated, we're trying to obviously follow infection control guidelines. So we've implemented where patients, we're sort of restricting the number of patients that can be seen in the office per hour. So generally we're only having in-office visits about an hour, and keep having patients check in from their vehicle to give us a call or text message us when they're here, so that we can make sure that the waiting room is empty, to bring the patient in and adequately room them, and then also following CDC guidelines and infection control guidelines for the use of our HSAT equipment, as well as utilizing mail order HST. So if we go to the next slide, and again, I think this has kind of been covered, but let's go to the next slide, and I'll kind of go through our process. So generally, we are, a lot of states, especially Texas has allowed for telehealth, but as mentioned, CMS has loosened their face-to-face requirements as well as their telehealth requirements. So telemedicine is now available to a larger population of patients. And so we have moved all of our office practices and procedures essentially online. So we'll have patients schedule their visit online via phone call, but we can send them all of our paperwork digitally, where the patients can fill out any paperwork, even as a new patient or as a follow-up patient, whether it's an Epworth scale or just how they're doing symptoms-wise in advance of their appointment. We get that information and can sync it to their chart for their office visit. And then when they're checked in, then we can usually have my staff about 15 minutes to 30 minutes prior to their telemedicine visit, check in with the patient, make sure that they have everything ready to go for their telehealth appointment. We'll see them for then I will log in, see them for their telehealth visit. And then we can coordinate, mail order HST if that's necessary. Certainly with many of the newer PAP devices, there are online cloud-based portals where you can view their data and make adjustments. And then we typically just bill either based off of time or based off of the same parameters you would for a normal E&M visit, whether it's a new patient or an established patient. Billing very similar to that, and I've included those E&M codes on this slide. If we go to the next slide, in terms of how we've been handling testing, I've generally been using home sleep testing for quite some time anyways, but there are several different mail order ST options, and this is by no means a comprehensive list, but certainly, there are companies that offer mail order services like CleveMed, Itamar with WatchPad or WatchPad 1. There are other companies that can do mail order HST using WatchPad or ResMed, such as iSleep. And then DreamClear is a newer company that also offers a mail order option where these companies will mail out HSTs directly to the patient. Some of them are disposable. Some of them allow for an upload immediately after the patient has used the device, so you don't even have to wait for the device to be returned to interpret the HST, and so that can help when you're worried about expediting care, how long will care be delayed. Generally these devices can be delivered to patients within just a few business days. And so I haven't found that it's been very helpful to have these services available to our practice, especially when we were kind of completely shut down from seeing patients in the office. And so that was helpful to allow, while we were seeing patients, to still have testing occurring. And then now that we are able to do HST, we are offering HSAT through the office, following the procedures to properly disinfect the equipment, and still using mail order options for patients who may live too far away to drive to the office, or who just feel more comfortable doing HST testing. And then we are obviously prescribing, if we need to prescribe PAP therapy, using devices that do have data in the cloud, so that we can access that data and make adjustments virtually as well. So happy to answer more questions later, but you can move to the next slide.
Thank you, Dr. Jane.
Okay, thank you, Dr. Jane. So we will move on to Dr. Vishal Patel. He is an internist and sleep specialist who trained at Cornell University for medical school and residency. His passion in patient care and operations has led him to take on a role as Director of Operations for Cedar Park Regional Medical Center. He is also currently the Director of Sleep Medicine at Cedar Park Regional Hospital. He has been able to use his medical training alongside his administrative acumen to build one of the most successful sleep programs in Austin. He is currently a member of the AASM and hopes to navigate sleep medicine into the future. Thank you, Dr. Patel.
Thank you for the introduction. So what we want to go over today is kind of, we've opened the lab for about 2 weeks and how we went about it and what exactly we did in the process. Can I go ahead and get the next slide? So the biggest points that I think everybody's facing right now is how do we keep our staff safe, our patients safe? How do we get them in and actually mitigate risk? You can go to the next slide. So this is what we're doing right now as far as PPE is concerned. If you're doing a PSG or a diagnostic study, I mean, I've listed them, but everyone's discussed the same stuff: a surgical mask, ideally a face shield, a gown, and a set of gloves. When we're going into titrations, I would highly recommend N95s because that's what we're trying to use, and we've fitted all our staff for it as soon as we start titrations. We haven't started titrations yet. We're starting in 2 weeks to see how the first 2 weeks goes with just opening a lab, see how we can actually, take care of our patients, make sure they're not at any risk. These hyperlinks at the bottom, if you click them, that'll go to other slides, but we can go ahead and go to the next slide, and I'll revisit that when we get to the slide. So this is kind of what we're doing before we actually start scheduling. Me or the other 2 or 3 doctors that are in the clinic, we're usually reviewing the orders, looking at the medical history to make sure there's no underlying comorbidities that we're really worried about. Usually we're really concerned about any deep pulmonary issues that are not listed from referring providers because they're not all from our clinic. We get primary care that refers to us all the time. So we're kind of going through that, going through the medical records, make sure there's nothing there that we're really concerned about. Once we sift through all that, we think they're a good candidate to come in or be an HST. We give it to our staff to schedule. They go through a list of screening questions. If they pass all those screening questions, they discuss all the steps that we're trying to take to make sure that they're safe. That if it's a home sleep study, it's a drive-through service. They call us when they're here. We go down, we drop it off in their car. We pick it up when they drop it back off, and we don't use that machine again for a week. We don't even open it for a week to decontaminate. We keep it in a plastic container. Stays that way for a week. Then we open it, we disinfect, then we upload the data. So they know that there's going to be about a 2-week delay time on getting results from us because that's what we're doing. We also try to email our patients paperwork so they can fill it all out, email us a driver's license, insurance card, all that kind of stuff ahead of time so that there's less transferring of paper or documents, anything else. We use a form, a website called JotForm. It's actually HIPAA compliant. You can make your own form and you send them the link. They fill that out online, hit submit, it comes right back to you. So we found that one pretty easy. Next slide. On the day of the study for in-labs, we're gonna call them in the morning. Our day staff calls in the morning to confirm the appointments, go over the screening questions again. So this is the second time we're asking the same questions over and over. We also tell them when they do come for the visit, they are required to wear a face mask or face cover to be able to be allowed into the facility. The night of the study, when they come in, they're actually calling from downstairs. They're calling our office. Our techs are picking up the phone, and they're going to ask them those questions again. So we've already screened them 3 times, and by 3 times, if something slips by, we did our due diligence to make sure it's the safest we can. They're also told again to wear a mask before they come up. If they come up without a mask, we will not let them in. So what happens is the first set of PPE is put on now, like the gowns, the face covers, the masks put on when our staff goes to receive them at our front door. They check a temperature. The temperature's fine, then we allow them in, we walk them into the room and start the process. Next slide. So I put some tips on here that people can review later. Right now, what we did when we first started, we opened 2 weeks ago, we're just doing 1 tech a night at 2 to 3 patients, depending on your ratio protocol. Ours is 2 patients, 1 tech. We also make sure our day staff and night staff never overlap. The building has to be completely empty before day staff walks in. Day staff does their thing and they completely empty before the night staff comes in. So there's no crossing of daytime and nighttime staff. We also schedule these patients to be 30, 45 minutes apart from each other. So there's no multiple patients coming in at the same time. Once we bring them in, we actually put them in their room. So they're already quarantined per se in their own room. So they're not coming in contact with other patients throughout the night. What we do for safety on our side is we have a 6-bed lab. So we use right now 2 rooms a night. So once those rooms are used, we keep the doors shut for 3 days before we open them to actually sanitize and clean them. So anything on the surface level is usually already taken care of itself. Then we go in there, clean, disinfect, and then reuse the room. So we do separate the days. We try not to use the same rooms multiple nights in a row. We are one of those very few facilities that still uses the same, an actual mask to do titrations. We actually disinfect everything pretty well, but we've actually converted over to a disposable model right now with our leads, our masks, our hoses, everything just to make sure everything's taken care of as best as we can. The morning after the study, same thing. We make sure that patients do not walk out at the same time. They're not usually allowed to leave their room without supervision. We just use a germicidal wipe to wipe down all the electronics, the beds, the furniture, everything like that. We also recommend that our staff change clothes. So whatever they've gone into, come in contact with, those kind of things, and kind of stay in a plastic bag. They take them home, throw them in their washing machine or in a room until they're ready to wash them. So they're actually going out into public with a clean set of clothes on. If you can, ideally get the patients tested prior to your titration. That would be the ideal setting. In Texas, there are quite a few facilities that are now testing, antibody testing and PCR. In Austin, we've been lucky to have a few of the physician premier ERs do testing. You can literally send a patient there, they'll get tested. The issue is, like, if you're in from the Austin area, the Round Rock facility is overwhelmed with patients, so it does take a little longer to get these results. Can patients stay, self-contained in the manner of your results in the study? Unaware, but it's one other step that you can take before you start doing titrations to make it a little easier on yourself. The other big thing is I would definitely reach out to your local reps. They're a wealth of information. If there's any questions, concerns you have, they could probably handle them better than you or I could probably think of. We made a few different changes. Go ahead and go to the next slide. This is what our schedule looks like right now. On May 4th, we open. We're still at 1 tech, 2 nights. On Monday, we're starting with multiple techs, multiple patients. And we feel comfortable that June 6th is a pretty good date because we've had multiple sets of patients in here at the same time. We should be able to move towards titration starting. Again, we don't have any negative pressure rooms. The only negative pressure room we have is our soiled room where we do all the decontamination. So we're trying to decrease the number of titrations per night to make sure we're staying as safe as possible. If everything goes well till the end of June, then we should be full service throughout. Next slide. So this is kind of what we do for our PPE. They get 1 set per patient. And as soon as they walk out of the room, we put some command hooks. It doesn't look pretty, but that's what we've done. And they kind of hang them on the hook on the outside of the door. So the other patient set gets hung on that door. So they're never taking equipment they have in patient A's room into patient B to kind of keep it as contained as possible. We also ask the patients, like I said, when they go receive the patient, before they even walk into the office, they're in the PPE just to help mitigate any risk. At the end of the shift, they put it in a plastic bag and we call it and toss it all. Next slide. This is what we're kind of looking at for titrations. We're starting, like I said, in about 2 weeks. We've kind of made shift something. There's no clear answer to what we can and cannot do right now to help mitigate spread to a titration, but we have some non-vented masks that we've kind of made shifted together with the HMEF and then a leak valve. The only concerns I have with this kind of setup is if you have patients that are needing VAPS treatment or anything like that, high pressure, and it's going to also be an issue with CO2 monitoring. So if you can monitor CO2 closely, that would be highly recommended if you're going to use a contraption like this. We're going to start using it in about 2 weeks. I would love to give feedback to everybody. The other thing is I would make sure the patient knows this is not what they're going to go home with. This is not what they're going to use at home. So if they're uncomfortable at all, we don't want to scare them away from using the device as a whole. Next slide. I just put a set of screening questions in there that we usually use. Have you traveled outside of the city? We don't even say state anymore, outside the city in 14 days. It gives us a better handle of what we're dealing with. Have you come in contact with anybody with COVID? The fever, the loss of taste or smell, any GI issues? It's the same run of questions, but again, they're updated weekly. So I would check the CDC or the ASM for more accurate questions as time goes on. The medical questions that we actually have our staff ask the patients is actually, are there any pulmonary issues or illnesses that we are not aware of? Because sometimes when we get it from primary care or anywhere else, we might not have a full scope of what's going on. If they have asthma, we do ask them if it's routine asthma, PRN stuff, exercise induced, allergy induced, then we're okay with them. But if patients have COPD, emphysema, we're really cautious of if they actually come in lab. Usually we'll do a HST first to see what it shows and then kind of go from there. But we have not titrated anybody and we're not going to start for about 2 weeks. Next slide. That's what I got from our side.
Great. Thank you so much, Dr. Patel.
No problem.
So we are going to go ahead and proceed with the question and answer session. We really appreciate our 3 speakers for today. Before we proceed, I just want to remind everyone that we are not giving CEUs for this session, but the TSSP is working on upcoming virtual meetings, and so please check your emails in the future for any future events from us. The question and answer session will be moderated by Dr. Holt and me. The panelists includes Dr. Barantes Perez, Dr. Jain, Dr. Patel, and Dr. Phil Alapat. I would like to introduce Dr. Alapat before we proceed. He is an assistant professor at Baylor College of Medicine, Department of Internal Medicine, and Section of Critical Care, Pulmonary Critical Care and Sleep Medicine. He is the program director for the Sleep Medicine Fellowship at Baylor and associate medical director at the Baylor St. Luke's Sleep Center and pulmonologist for Baylor ALS Clinic, period. He has contributed to and published numerous research articles and educational material on pulmonary sleep and critical care. One of his honors includes being awarded the Outstanding Sleep Medicine Faculty at Baylor in 2017. He is a member of the local and national committees, including AASM as a member, and he served on the Sleep Medicine Fellowship Directors Committee. So what we will do, and if you have more questions, please put it in the chat room so we can keep adding to the list of questions for our panelists. Before I start, Dr. Barantes actually posted some information on getting drive-through testing for COVID, if you want to look in the chat room. So one of the first questions that we have is, how are you prioritizing the patients who come in first? Who do you consider emergent? If Dr. maybe Patel and Barantes can take this question.
Sure. When we're going through the medical history, our pulmonary patients are most concerning, especially CHF patients. If we have those and we can actually make sure that they're safe coming into the facility, they have no ongoing current issues, we try to get them in and out as soon as possible. You know, we have a lot of patients that, you know, they have spouses complaining of snoring, and so forth. Obviously, those don't fall to the top of our list. When we get to them, but we do try to get everybody out on HSTs that are like that. But if we have pulmonary cases, we're usually doing Entitle. We have bariatric cases over 45, BMI of 45. We're always doing Entitle, so we want to get those patients in and out first.
I will say every patient that is at risk of being readmitted soon enough to the hospital, and it will be at greater risk of getting COVID during the hospital stay or during the commute to the hospital, those patients are the ones who are emergent. The regular patient that requires PAP but can be out of PAP, those are not. But whoever is going to be at risk of being admitted for the lack of adequate therapy, or the ones that cannot reach adequate therapy and they are going to be admitted for the hospital due to the lack of PAP, those are emergent cases.
Thank you. The next question is, what is the best way to clean the equipment, or should we use disposable testing equipment? Could Dr. Barantes Perez and Jane address that?
Well, the CDC has posted what kind of cleaning solutions can mitigate or can kill the coronavirus. What you should be doing is review with your manufacturer's manual what solutions you can use in your equipment without damaging. That's specifically for the electronics. If the parts that you can submerge in water and soap, as many centers do, that they just put chlorhexidine impregnated solutions to submerge those equipment, that's still pretty valid. Usually those kind of equipment that you're submerging, mask, tubing, corrugate tubing, if you submerge them in a solution of 1 to 10 of chlorine, hydrochloride chlorine, the Clorox or things like that, that will kill all the viruses. It will then damage the DNA of the virus, no matter what virus, HIV, all other virus. The coronavirus is no exception to it. So that equipment can be sanitized or it can be reused if you do that. Filters are not recommended to be reused. If you are going to reuse filter, there are some reports that some centers do for the regular ventilators. So they put them in a treatment with ethylene solutions that are vaporized, and that kill the virus, but also that damage the filter in the long run. So there is no good description how many times you can run the filter to that decontamination process without damaging the quality or the pores of the filter.
Yeah, and I guess I would also, just echo that. I think, like, at least that we're doing a bit of both, because as all of the other presenters have mentioned, the idea is like, how can we best mitigate the risk? And just like, the recommendation is everyone should wear a mask, which is great, but where do you get, an endless supply of masks for when everybody's trying to purchase masks right now? So it's the same thing with disposable HST equipment. As mentioned earlier, there's basically one company that offers that, and everybody's trying to get it. So we've been trying to take an approach where, we use a little bit of everything, so that not one particular piece of equipment is just completely out, so that we can use our HST equipment and be sanitizing that. We use mail order as well, and that's where we're also using telehealth versus in-office visits to help limit the amount of PPE we're having to utilize in our office.
Great, thank you. And there was a chat room question for Dr. Barantes. Are there any approved UV light equipment to disinfect the rooms? Dr. Barantes, I think you're still muted.
Sorry. There are multiple brands of equipment that are approved by the FDA to decontaminate the rooms. There are Clorox makes one. There is another one, Alistar. There are different brands out there. So few of them are more expensive, few of them are cheaper, but they run around $10,000, the hospital side ones, between $5,000 and $10,000, and it takes 15 minutes of the UV radiation. There are also available blueprints how you can build your own UV light device, and they were given without any patent at the beginning of the season of the coronavirus, and they're still free there. But you have to be mindful is that first you can expose yourself directly with that UV light. The risk of melanoma and basal cellular carcinoma is high, and also to develop cataracts. And the other thing that you have to be mindful is that there is a certain range of the UV light that will kill the virus. For example, the UV light that you use in your regular CPAP cleaner at home, the ones that are UV light based, that one kills the virus, and that one doesn't denature the N95s in the first 5 uses. So that kind of wavelength for the UVs is the one that you should be using. But pretty much there are several brands. You choose which one you would like to use, the one that you can afford, and do it safely.
Thank you. The next question is, should there be different types of PPE used for diagnostic versus a titration?
Yes, if it's a diagnostic, one of the panelists mentioned before, the face mask is the basic requirement. But ideally, if you have a eye shield or the face mask with the shield and gloves and a disposable gown, that will be enough. But if you are going to do titration, N95 is the minimal requirement on top of the gown and on top of the face shield. So you're doing droplet precautions with face shield in order to prevent you absorbing the virus that is being aerosolized. And if you really want to keep your lab going and keep it safe, you should consider making a room that is suitable for it. So constructing a brand new lab, and this time is impossible. You're not going to do negative pressure rooms for everybody. It is too expensive. It's too expensive. You cannot get it done. It's not cost efficient. But a high filter, a high circulation HEPA filter, that could be a potential solution in exchange for a negative pressure room. And most of the hospitals across US are having success with that, and they don't have a high rate of infection between workers or patients. In fact, in St. Louis, we are using that, and we have great success with it, and it's very inexpensive compared to building a negative pressure room.
If I may chime in for a second, when these N95s are really hard to come by, and we understand that not everybody can get them, but when you do get them, if you can get surgical masks, I mean, everybody anywhere is making surgical masks. Now we need booties and hairnets, and we can't get those because those companies are not making surgical masks. So I think surgical masks are attainable. So I think if you cover your N95 when you go in for a titration with a surgical mask, at the end of the night you can dispose that, and you should have no quorum in that. The N95s are hard to get in a particular size. So you brown paper bag them, keep them for 3 days, and you can open and reuse per the same employee that works 3 days later. You can reuse the N95s if you take care of them with covering them.
Correct. The other alternative, you can sterilize them, and the equipment that can sterilize them is available even from your own DME. The CPAP cleaners with the UV light. The ones that don't have any moist on it, the peroxide ones, or the ones that generate ozone that will damage your mask. But if you just want to sanitize it and sterilize it, you can cycle it up to 5 times using the UV light in a safely manner. They disclosed in, I think it was University of Pittsburgh and Stanford, that in order to achieve full decontamination, if you need a quick decontamination of the mask, you need to do 30 minutes of that regular CPAP equipment cleaners. Otherwise, you just can wait 3 to 5 days in a paper bag, and that will let the virus die. Don't use a plastic container because the virus will last longer in a plastic container. So it's better to have a breathable paper mask. The virus apparently only lives about 3 hours in the paper. So in your mask, it's gonna take a little bit longer because the filter has some polymers that are plastic, and it may take a little longer. So 3 days is what most of us we are doing. And at the point that we were very sure of the N95s, we opt out for doing that we were using the same mask for a very prolonged period of time, and we just were recirculating them with the same employee. So that give you a better option, because they are very hard to find right now. You're right.
Thank you so much.
I think Dr. John, I just wanted to interject something real quick. We have to be pretty clear about how at the current community transmission level that is the case, at least in Houston, we have to be clear that the current ASM recommendations are that PAP titration studies are essentially not to be performed unless, I guess, as Dr. Brantes said, in the emergency situations. So we have to be very careful about implementing PAP titration studies, and anything that is done, whether it's N95 masks or HEPA filter type systems, these are all mitigation strategies just to try to minimize the risk. And everything that we're doing when we're especially doing PAP titration studies is increasing that potential risk of transmission of the virus. I think everyone should be aware of that.
Correct.
That's a good point. Thank you, Dr. Alpat. And actually, that was leading into one of the questions we were going to ask about titration studies. I guess if and when we start titration studies, Dr. Patel went into kind of what it should look like with the filter and the whisper swivel valve and all that setup. But how easy is it to get these non-vented masks and filters and everything to put within the circuit?
I'm cheating because I'm a part of the hospital system. So the hospital system in our ICU, we have non-vented masks, right? So everybody doesn't have availability to get those same masks. So I think this is when we have to reach out to our local reps and say, hey guys, like, look, we got to solve this problem somehow. You need to help us out. We need your help. Saying, hey, we need these masks. And if they're only allowed for hospitals, what do we do? Because everybody can find the bacterial viral filters and stuff like that, but finding a HMEF might be a little tougher, right? The swivels, I think you can order on both. We use Philips and we use ResMed, so I think we can find them on both their websites. But I think the non-vented mask is going to be the biggest problem to find, and I would definitely get with your local reps to try to see what they can help you with, to try to see what we can do to kind of get past the non-availability.
Yes, thank you. And then the next question on the list is for Dr. Jane and Alpat. How do you determine when HST should be done over a PSG?
I mean, I think we can begin. The standard of care in HST is that the vast majority of the patients should be able to have an HST for diagnostic purposes if appropriate criteria are used to determine the success of, or the ability for that HST to diagnose successfully. Obviously patients who are using significant levels of oxygen and have significant other perhaps difficulties in wearing an HST device would complicate the use of the HST device to diagnose obstructive sleep apnea. But this criteria is fairly well established, and most insurance companies will probably give you that criteria as well.
Okay, thank you. The next question is for Dr. Jain. What should the procedures look like for delivering and returning HSTs?
I think a lot of the other presenters already sort of went through what some potential delivery and return procedures can look like. Again, using mail order is pretty easy because it just takes you and your staff and your clinic out of the equation to even have to worry about the delivery, especially if you can use disposable HSAT, because once they receive it, nobody's ever used that device. They're wearing it for a night and they just throw it away in the garbage. So that's generally been our go-to. When we are giving out devices, again, same thing where we'll have patients show up in the parking lot. They'll text us that they're here. Staff make sure that nobody else is there. We bring them in, we get their device. We then, upload that data. We'll review the data with the patient, and we take that device out of circulation. So we're only putting out our devices about every 3 days. And I have a set that goes out on essentially Mondays and a set that goes out again on Thursdays. And then we'll use those as needed as well.
Okay, thank you. And then there's a question in the chat room that says, and this would be maybe for Dr. Alapad and maybe for Dr. Patel, are you excluding in-lab PSGs for patients with significant risks like they're over 65 or history of lung disease?
Yeah, the AASM has actually published it fairly clearly what the higher risk individuals are, and unfortunately it includes the majority of the patients that we see in our sleep centers. They include severe obesity. BMIs greater than 40 are listed in the higher risk category. Patients with chronic lung disease, severe asthma, and anybody over 65. And this is because these are the patients that have been recognized to have a much more severe manifestation of COVID related complications, including acute and chronic respiratory failure. So it's very important, I think, that everybody recognize that all the stuff, Dr. Barantes and his crew have taken a great bit of time to put this information together, but it's very clearly published on that AASM website.
Correct. And it's available not only for members, it's for everybody. We make sure that it was no limited to the members, so everybody can access it.
Thank you. And then another question that I think Dr. Barantes answered in the chat room was, does Medicare still require in-person setup in order to cover CPAP? Dr. Barantes said, no, Medicare is not currently requiring in-person. The next question is for Dr. Jain, how many nights are you having patients use the sleep HSTs, and can you bill for multiple nights?
So the billing question is always depends on the payer. So you'd have to check with your individual payers for that. Generally, we're just having patients do, at least from a billing standpoint, we're just billing for one night. Obviously, with the mail order disposable, it's only one night anyways. If I have patients generally take home a device, if it's like through the weekend, then I'll usually let them wear it for more than one night, and we'll just take the best night of the data that we have available.
Thank you. And then for Dr. Jain, how can telehealth be used for HSTs in regards to delivery to patients, downloads, patient follow-ups, etc.?
I think we already covered a lot of that, but again, a lot of what we were doing in person can essentially be done virtually. So, I mean, obviously with telemedicine visits, we can see patients. There are forms and different technologies out there to collect information in advance of the visits. I mean, even before we were all forced to sort of use telemedicine, many of us in the sleep medicine world have been using virtual methods, right? Like many of the PAP devices, we have to go on a virtual portal to get the data. We've already been used to doing that. To make adjustments, we often do that on the portals. So we've been able to make care for patients virtually for quite some time. So it's just learning how to transition the before and after care and the actual visit to an online model.
Right, thank you. There was a couple of PD questions that I was going to answer. One was, how do we schedule pediatric patients, and should we screen the caregivers? We are, you know, PD is probably one of the later ones to restart. It's probably best to start with the adults, get that plan sorted out on the process. Some labs do COVID testing, some don't. Screening, yes, for everybody. Including the caregivers, because basically if the caregiver has fevers or symptoms, you're exposing everybody else to the possibility they may have COVID. So the next is, will PPE scare kids? If they're young enough, maybe. We in the pediatric lab tend to do a lot of coaxing, and we have like dolls and stuff where we put masks on. We do different things to just show the child, the young child, that wearing PPEs are okay. And most of the time, parents are now, a lot of parents are wearing masks, so that doesn't scare them as much. If all else fails, you bribe them with some stickers or something disposable that you can give them as little gifts. Sometimes that works, and sometimes there's just nothing you can do with kids. They're just going to be scared about it. I think there was a question in the chat room that says, are all labs allowed to do titration studies right now? And I think Dr. Alapat kind of alluded that we shouldn't be doing it, but allowed is a different question, I think.
Yeah, these are the ASM listed, everything that's listed on the ASM website are recommendations. And you know, at all times, what we're trying to do is effect the best care possible in the safest manner possible. And I think that's what the ASM recommendations are aiming towards. And the same recommendations that we are implementing here in Houston may not apply to Alpine, Texas, which is a very small city that, if I remember correctly, has a very low prevalence of COVID.
Okay, very good. Thank you. There's one question in the chat room. It says, being that Medicare does not require in-person setup, is there a code to bill for telehealth support with the RPSG education for CPAP setup? Anyone?
I think that code has been there for a while. It's not new. I don't remember the exact code, but yes, you can. And currently, if you don't have to have a formal encounter with the patient to document the physical exam in order to bill for the full encounter. So you can do a new encounter level 4 without having the component of the physical exam. And as far as you have documented your other components of the review systems, the past medical history, past surgical history, and the review of medications and the complexity of the assessment and plan. If you meet all requirements, Medicare is not requiring you to do your component of the physical exam. Now, for the counseling, there is a specific code for that, but I don't know the code, the CPT code. But if you go to the ASSM, there is a special area for coding, but I think that one requires membership in order to see what are the codes. There is in the website, there is an area for coding that has all the codes available. But I'm afraid that one, the ASSM requires you to have a membership.
One of our attendees said it is 99453. So I think you just need to double check that to confirm that. I think Dr. Holt had a question.
Yes, for Dr. Alapat and everybody, as a matter of fact. So the idea is that doing titration studies is supposed to increase like an aerosolization risk, but is exhaling through a heated humidifier supposed to increase those aerosolized particles, and is it really aerosolized? And should we stop using heated humidification for titration studies for the time being?
As far as I know, I don't think an exhalation port is ever connected to a humidifier. So I don't know that the humidifier is serving as a filter of any kind for exhalation. But anytime anybody breathes, there is an element of aerosolization. So just you standing in front of somebody who may have COVID puts you at risk, even though they're not coughing or sneezing. Even when they're talking, there is some aerosolization that is being put out.
So how's it tied into a titration study where everyone thought that there was going to be an increased risk?
So in a titration study, what's happening is that there is humidification that is also being collected on the mask. And as much as you are going to try to maintain a seal, the aerosolization part is going to exist no matter what. But some of the spray of the respiratory droplets and such is an additional part. The airflow is increased when you have positive air pressure via a mask. And so that aerosolization that you would have normally happened is now being sprayed at with increased speed outside of what would normally be spread by just normal talking and such. So that is the difference between a PAP titration study and a diagnostic study.
So there's still nothing that you guys could say that is truly airborne. It's just that a higher velocity of the exhalation could spread droplets further.
I think the worry is how far are you spreading it versus right now, you and I talking, I might be able to get it 2 feet, maybe 3 feet. But if I add pressure behind it, it's going to go a lot further. You're going to get surfaces that you did not actually consider being infected in the past, but now you've already got it all over your walls and you don't know that. And nobody's wiping down their walls every time somebody goes in there. So it just increases the chance because the spread is greater.
Yeah, and be mindful that it's not only the spray through the exhalation port, it's also around the mask. There is no perfect seal for a mask for every patient. Everybody has different facial features, so you will be leaking more or less. There is no perfect fit. If we have that perfect fit, many of our patients will not have much issues and the machines will not have leak compensation. So as far as you have leak compensation in your device, and all the sleep studies devices that we have, they have leak compensation, it will push more aerosol particles in order to achieve that compensation.
And thank you. And another question is if the home sleep study shows like a machine-generated central sleep apnea, are you guys comfortable with just ordering like a ASV machine or a BiPAP AVAPS device without a titration study?
You want to take a vote?
That's a difficult question.
That's a really tough one.
Yeah, that each patient is going to be different, and just because you see a few central events, I mean, you know, Rob Thomas likes to talk about the high loop gain type patient with obstructive sleep apnea, and you know, each patient is a little bit different, and ASV and probably not AVAPS, but is not the first treatment that we normally look at. You know, there's even literature that suggests the use of hypnotics may be of some benefit in these types of patients. There are lots of different things that we can do, including acclimatization, as this is likely occurring usually during the initial phases of use of PAP therapy.
All right.
Great. Thank you, everybody. I think that's all the questions and answers. There's a few more, I think, information in the chat box if everybody wants to review. I don't see any specific questions, just a lot of comments and inputs. I want to thank everyone for participating. Thank you for attending, and we definitely want to thank our presenters, Dr. Parantes Perez, Dr. Jain, Dr. Patel, and Dr. Alapat. Like I said before, we would like to keep doing these virtual meetings to really kind of keep us all updated on the current changes associated with COVID. and what we can do to open our sleep labs more successfully. So please give us some feedback and anything else we can do for the community. Thank you everyone for attending.
Thank you guys for putting this together.
Okay, thank you.
You guys, thank everyone.